Dr. Martin, and welcome back.
How are you, Diane? Good to be back with you today.
Thank you. Unfortunately, we are discussing a very sad, tragic event that occurred this month in England with a young woman who suffered from endometriosis, Amy Ganner. She had an accidental overdose of pain medication trying to control her pain based on the coroner's report. This is a hot topic in terms of endometriosis and prescription medication. The news article said that she had an inadvertent misadventure. For layman's terms, what does that mean?
So coroners have their own language about how they say things. Basically, that means that she was taking a legitimate prescription that had been prescribed to her and took too much unintentionally. So some people take more because they're trying to take more, but some people don't. That almost sometimes means that either she was depressed and didn't realize how much medicine she was taking, because I've seen patients who are depressed take narcotics to try to control the depression without realizing that's what they were trying to control. So they'd be better on antidepressants than narcotics. But in this situation, it means that she was taking legitimate medicine, just took too much of it, and it was her medicine. It was all prescribed medicine.
Those that are being prescribed medication to treat pain related to endometriosis, is this a wake-up call? Should people be afraid that an overdose is a potential hazard of these medications?
Yes, overdoses have always been a potential hazard. Lots of studies on that dating back 50 years. This is not a new issue. If we want to, let me just for a moment show you some slides on doses. It's 8 slides, so it won't last long. Just to give people an idea, just give everyone who's listening an idea of what we mean by what it takes to produce an overdose.
Okay.
So if we look at that, this, for anyone who wants to review these, that's going to be the link. I've got that link up again at the end of the slides if you don't have time to write it down fast, or since this is recorded, you can play back to it anyway. But it's going to have the news article that we're talking about from Manchester, England, slides on narcotics, which are the slides we're looking at now, comparison of short and long-lasting antibiotics, and 2 articles on tramadol, because she was on tramadol, and there is a lot of press about tramadol being safer. Mm-hmm. Tramadol is safer if you respond to it better. It's not intrinsically better, but it may be safer if you respond to lower doses. That all has to do with dose things. Okay. The reason we get into this is because we have a 3rd wave of our epidemic, and that 3rd wave of the epidemic has to do with synthetic opioids, which includes not only fentanyl, but if you look at it, there's our tramadol right there in this 3rd level. The link to that is at the bottom of this slide for anyone who wants to look at that. There's a lot of things that we'll talk about morphine equivalents. When you read all these names, they all mean basically the same thing. We just need a standardized dose so that we can compare narcotics. So these all terms mean basically the same thing. And that gets important because we're using doses in terms of morphine equivalents anywhere from 18 a day, which is 4 Tylenol 3s a day, up to 4,500 for oncology inpatients.
Wow.
The interesting thing about that dose is that at that dose, a patient with bone cancer, metastatic bone cancer, is actually more alert and breathes easier at the appropriate dose than if they were not on it. So they may actually live longer on that dose than shorter, which was one of those worries we always had. But the doses are really high for hospice and oncology and end-of-life care, and relatively low for basic health care. And in between are the pain clinics. Now, back to where we were. What is the risk of an overdose?
Right.
We pretty much know that the risk of an overdose below a morphine equivalent daily of 50, below that daily is quite low. It's very rare to see an overdose below 40. But if you compare that dose below 50 to the dose above 90, there is a 10-fold increase in the chance of overdose. So when you ask the question, should we be worried about overdose? Yes, particularly if you're on doses above 90. So we want to look and see what that 90 means. And in general, for someone who's taking a Percocet 10 4 a day of those has a morphine equivalent daily dose of 60. That means that they're about twice the risk of someone who's taking either a Lortab 10, which is a hydrocodone 10 or hydrocodone 5. And in between that is that Percocet 5 or oxycodone 5 milligrams, which would be about 30 per day.
So
Tramadol 25 to 50 is in that low level. But if you get into Tramadol 100, then you can't take so many because you've got to back down. So it's not just the name, it's the dose that counts.
so this comes down to the first dose that someone gets, that they're in need of this pain medication, and let's take it out of the hospital population and into being in a doctor's office, being given a prescription. How does a physician decide how much dose a patient should be given? Obviously, it's based on weight. Is it necessarily based on pain level? How do they come to terms with what the dose is?
I can't answer for everyone. I can just tell you what I did. I generally started with I'd ask the patient if they'd done well on something in the past. And if whatever they'd done well in the past was in the range that we showed, we would start with that dose. And I would also use something like either acetaminophen or an ibuprofen, a non-steroidal anti-inflammatory agent, because the combination of the two of those combinations can hold down the total narcotic dose.
Okay.
And then we just slowly titrate up. I take them up to, so in my practice, if you look at a general endometriosis practice like I'd had, which was mostly referral, where 72% of my patients had endometriosis, 99% of patients can be held below morphine equivalent daily dose of 60. So it was rare that I had anybody above a 60. If anyone needed more than that to control their pain, I'd get them to a pain clinic where the physicians were trained to handle that kind of dose, because I wasn't trained to handle the doses above 60. That's a different art than what I do. There are a lot of physicians who cut off at morphine equivalent daily doses of 20 and 40, and there's some who just won't prescribe narcotics at all.
Yeah. The article also said that that she acted out of it, that she was fuzzy while she was on this medication. Is that normal if you're put on a pain medication?
If the dose is titrated the right way, so this all comes from Sidney Snow back in the 70s. If you get them on the right pain medication, they will be more functional and do better. They don't get drowsy. So if you can find the right dose, then you can generally avoid that drowsiness. Not all the time, but most of the time you can. Very few of my patients, once we had them titrated, had drowsiness as a problem, but titrating it could be a difficult thing to do. But if you back, just let me excuse me, I dropped something right there. But once you know somebody's getting drowsy on the medicine, then they need to have it adjusted if they can adjust it. Now they may have already tried to adjust hers and just weren't able to do it. But boy, if somebody's getting drowsy, that's a warning sign that they're already at a level that's dangerous. And my guess is, remember, she was on a combination of both morphine and tramadol. The chance that her morphine equivalent daily dose was greater than 90 or 100 is really high. My guess is that she was probably in excess of 90 or 100 using that combination.
What are some of the symptoms that you're on the wrong amount of pain medication?
Oh, you're still having pain, obvious one. That's the wrong dose. You're getting drowsy. You're falling asleep. You're not thinking as well. You can't remember what's going on.
Oh, wow. You
just feel, how people talk about feeling like their endometriosis is active or their hormones are off. There are people who can tell you that their narcotics are off. So there's just this general sense of, somebody the other day asked me, what does it mean to feel hormonal? I said, I don't really know what it means, but I sure know what it sounds like because I hear people tell me. It feels the way it feels.
Yes.
And the same sort of thing's true of narcotics. It just feels like something's off them.
And now this is something that might be helpful to someone who either has endo, is a loved one of someone who has the disease. what are signs of the beginning stages of an overdose?
Oh, just like they said in this thing, she was acting out of it. She was slurring her speech. I mean, both of those were in that article. I mean, that's just, you hear somebody slurring their speech, you just wonder, you know something's off. Not my patients on the right dose. I don't ever remember a patient on the correct dose once we had them titrated ever slurring their speech.
Mhm.
That just suggests that something was off at that point in time. Uh, Now, she was in a referral system where her primary care physician could not even get her to her gynecologist. So much less get her to a pain. I'm not sure if he even got to the point of getting into the pain clinic. Uh, it's one of the problems right now that we had when I retired from practice. I yearly I had about 400 patients a year on narcotics, routine as clockwork. Out of that 400, about 350 were short term related to surgery, cysts, kidney stones, other things like that. And they were off within 2 to 4 weeks. So we're talking about 350 on them for 2 to 4 weeks, and that was it. Another 25 were on them for anywhere from 1 to 3 months. And those were all trying, most of those were post-op. So we're trying to get them off their narcotics after surgery. But I had 25 a year who would be on them for more than a year. And as long as I could keep them under 60 at that time, and this, remember, prior to 2016, 60 was thought to be low dose. So most of us were trained at a level of 60. Right now, the CDC thinks that number should be more like 20 to 50. So that number drops over time. But all of mine were kept at lower than 60, or I got them to a pain physician. But that meant that was about one patient every 2 years. So about one patient out of every 800 that I was taking of that I'd have to send off to someone else. And they did not slur their speech. Mm-hmm. The times they would get drowsy, the times I worried about it most were like right now. It's 92, 95 degrees outside. If somebody goes out and gets in their car and their car's 105, 110 degrees, they're going to get worn out just right off the bat anyway. So it wasn't just the narcotics by themselves, but other things that made it worse, like heat, wore them out, stress of having to take care of their children full time. Their children are pushing them. I mean, if it's like me, I'm right now taking care of my son's dog, and the dog wears me out. It doesn't take much to wear out a 75-year-old because I can't walk at his speed for 45 minutes straight.
I also want to talk about really a broader issue that has been raised because of this tragic, untimely death of this woman with endo. Some say that the system failed her because putting an endo patient on prescription medications and concealing or covering up a problem is not getting to the root of the disease. And therein lies a major issue.
That's a good question, because when we talk about system failure, we have to talk about, do we have someone with the expertise to take care of a specific type of surgery, a specific type of endometriosis, either surgically or medically? So those of us who were trained in excision in the 1960s, I'll get the year right correctly. So in the 1980s, when we began doing laparoscopic excision, we'd been doing excision at laparotomy since the 1920s or 30s. So excision is not a new issue. It was just laparoscopic excision that had to be changed in the 1980s. So I was in that wave of people who did excision in the 1980s with David Redwine and Harry Rich and all those others who were doing that. And at that point, we pretty much resected everything we knew how to find. In this day, we have people like Mark Possover and Horace Roman who have techniques that Harry and David and I didn't even anticipate. So there is better surgery now, but the number of people who can use that kind of surgery is probably on one handful.
Right.
So if you're talking about what's available in general, then it's hard. So for the number of women who need that surgery, it takes a certain threshold of number of cases, and the number of people who are going to be trained, that's going to be quite small. how can we work around that in a system
Mhm.
is a difficult question. I don't know how a system fixes that, because at this point, if you want somebody who needs neuropelvic, it's Mark Pussover's term for neuropelvic surgery, and I can't get the term right. But if someone needs that surgery, the only three people right now I have to think of who I might refer them to, and there are probably a half a dozen more if I thought about it. But Mark's one. We've got Tamara in New York, and there is a surgeon out in Oregon that I know is doing it. But those are relatively few things. And I'm not sure how a system
Right.
can be designed that will get something that, so we're talking about 10% of all women have endometriosis. How do you get 10% of people to a handful of surgeons? I don't know how the system is going to fix it.
I have a friend who is in Canada,
Yes.
and she has had multiple excision surgeries, a hysterectomy, and now has scar tissue issues and endo adhesions that I guess they must have missed in a prior excision surgery. She has been on a wait list to see an excision specialist for over a year and is in chronic pain because of the way the healthcare system is set up. And this is so much of an issue because not only do we have limited treatment options within the endo community and healthcare system, and thankfully we have these brilliant doctors such as yourself and researchers who are trying to change that so that there's not just opioids and pain and hormone suppression, all these things going on, but it also comes down to, like you said, access to the care. And it does feel like a failure to a community that already feels like we have been put on the back burner so many times. Of course, we have people fighting for us, such as yourself and Dr. Setchkin and Dr. Goldstein and a number of other physicians, Dr. Harry Rich. But like you said, there's only so many of those, and issues and tragedies like the one that just occurred this month bring light to the shortcomings and the holes in the system.
Oh, yes. I wish that was not correct.
Yeah. So do I. And I do think that the discourse about it and people being cognizant, because like you said, if someone is dealing with this kind of level pain and they're giving prescription medication, for them to know what the signs are of the wrong dose, a possible overdose that could be occurring. This is where we're at now, that these conversations might help someone who might need to go back to their doctor and say, God forbid I become that very small percent, and they can pay more attention to getting the proper dose they need while they hopefully get into the right hands.
Even in the right hands, surgery doesn't cure all of it.
Yeah.
So when you said the adhesions were missed, you don't know if it was missed or if the adhesions were actually caused by the surgery. So we have that problem that surgery can make the problem worse by causing scar tissue.
Oh yes.
And we know more about how to treat endometriosis than we know how to treat scar tissue.
And that's a conversation that I would love to have you back on for, because you and I have talked offline about that. And I recently had Dr. Metz on, who is a brilliant researcher, and she was saying that they're trying to figure a way out to target scar tissue, to figure out the origins of scar tissue.
Sure.
Because a lot of the inflammatory process that people with endo have creates adhesions, creates scar tissue, and that's what really becomes problem. And that's a whole other side of the coin that causes debilitating pain and organ issues.
Yeah, as if one problem wasn't bad enough, two's worse.
Yeah. And when we refer to endo as complicated, it's just such an understatement, because it's a whole body process. And I'm just a civilian patient in all of this, and it blows my mind how I always come away with more questions than answers sometimes. But it's the quest. It's the quest of knowledge.
Having studied it since 1970, so I'm in my 51st year now, I come up with new questions almost every day. I wish there's a really interesting article right now that came out in the last 2 months from Canada. There was a population-based study that shows recurrence rates after surgery of 0.1 to 14%. So recurrent surgery rates of 0.1 to 14%.
Mm-hmm.
And that number is so much lower than the 25 to 80% that we're used to hearing that it's confusing everyone. And the answer for someone who's done research all their life is it's interesting, but it's not unexpected, because population-based studies generally have much lower incidences and prevalences of problems than tertiary-based studies. And almost everything we have in the literature is tertiary-based. That is, it's written by people like me. In my population, the easiest way to know if somebody had endometriosis with a 72% degree of accuracy was to know that they walked through the door. 72% had endometriosis. And if they told me they might have endometriosis, they did 90% of the time. And if they told me they did have endometriosis, they were right closer to 99% of the time. I don't really know that last number, but it sure felt that way. Women who told me they have endometriosis were almost never wrong.
Yeah. Yeah. And I again, it's always the theme of every conversation. The person with endometriosis knows their body better than anyone else. They've lived in it their whole lives.
Yeah.
They know when something is wrong. Thank you again for joining us and for putting a spotlight on a very important, very sensitive subject matter topic. So thank you. I appreciate you. And let's please have an episode dedicated to scar tissue.
Sure. Thank you, Diana.
Thank you.
Have a good day.